Hello, I'm Dr. Samuel Frank, and I'm the chair of this CME program, and today I'm going to be talking about the Huntington's disease natural history and an introduction to the whole series. These are my disclosures. And these are the learning objectives, not just for this particular talk, but for the entire series, since this is an introduction to the whole series. We're going to understand the diagnostic criteria and current neurologic management of Huntington's disease, also referred to as HD. We're going to understand the psychiatric manifestations of HD and their treatment. We're going to gain awareness of cognitive features of HD and the role of neuropsychological assessment. We're going to understand the benefits, limitations, and ethical issues of genetic testing in HD, and appreciate the role of the multidisciplinary team in the management of HD, including in long-term care settings. We're going to acquire the knowledge and understanding of prevalence and diagnostic procedures utilized for juvenile form of the disease, and expand understanding of unique issues pertaining to the quality of life in Huntington's disease. Finally, we're going to increase the knowledge of resources to connect Huntington's disease patients and families with clinical research opportunities in their geographic area. For my talk, specifically in terms of the natural history and introduction to Huntington's disease, we're going to go through a little bit of the history of Huntington's disease, then some of the epidemiology and clinical manifestations. We're going to talk about the diagnosis and a little bit into the genetic testing, as well as an introduction to some treatment strategies. In terms of the history, it's George Huntington who gets the name, but he wasn't the first to describe the disease well. Johan Christian Lund was a Norwegian physician, and in 1860 he very clearly described dementia, jerking movements that tended to run in families. Unfortunately, he published this not in English and in a journal that was poorly accessible, so his manuscript was not translated until 1959. In addition, there was a physician that confused what he had described with Parkinson's disease, known then as paralysis agitans, and so his description of the disease was delayed. Unfortunately, this confusion between Parkinson's disease and other neurodegenerative diseases in Huntington's continues today. George Huntington was a third-generation family physician, and he worked with his father and grandfather in East Hampton, Long Island. He originally read his report to the Meigs and Mason Academy of Medicine in Middleport, Ohio on February 15, 1872, and it was published later that year in the Medical and Surgical Reporter. His text was an overview of all causes and treatments of chorea, and in it he described Sydenham's chorea. He described some of the treatments including purgatives, tonics, counterirritants, and antispasmodics. The first indication this is a quote from the manuscript, the first indication is, if possible, to remove the exciting cause. So he was into root cause analysis even back in the late 1800s. And of course, he promoted bleeding. The last 7 paragraphs are really what he's known for in terms of the genetic form of the disease, or what we call Huntington's disease today. He described the hereditary chorea, and he described the 3 marked peculiarities in this disease. Its hereditary nature, and he was the first to describe that if a generation didn't get the disease, the rest of the generations would not get it after that. He described a tendency to insanity and suicide, and thirdly, it's manifesting itself as a grave disease only in adult life. Juvenile HD was described a bit later, in 1888, using data from 3 generations. Dr. Hoffman described the juvenile form of the disease. He described 2 daughters with onset at ages 4 and 10 years, and some of the differences that he highlighted were rigidity, hypokinesia, and seizures. About 100 years later, Dr. Ridley showed 2 types of anticipation from paternal inheritance. Anticipation is an expansion of the repeat for the next generation and results in slightly younger age of onset. In juvenile forms, it can be as much as 24 years younger than the previous generation. In terms of the epidemiology of Huntington's disease, it's estimated that about 30,000 people in the U.S. have the disease. And in terms of the incidence, it's about 5 to 10 cases per 100,000 per year. Not only are there about 30,000 people with the disease, but another 150,000 to 200,000 that are thought to be at risk. So they have a first-degree relative with the disease, either a sibling or a parent. It affects men and women equally, and the age at onset varies, but it typically is in the 30s and 40s. The age that's reported can be as young as 2 and well into older ages, into the 90s. The majority have a documented or at least a suggestive family history. 5 to 10% are estimated to have juvenile onset, and this is defined as the onset of symptoms under the age of 20 years. In terms of the diagnosis, it's a clinical diagnosis. So this is based on the history, family history, and physical examination. You can do other tests to make sure that there isn't another cause for chorea if it's indicated based on the history and based on your physical examination. An MRI is typically normal in early Huntington's disease, although there can be, in early stages or moderate stages, atrophy causing enlargement of the ventricles. People often say, well, if the gene test is positive, they have the disease. And yes, if the gene test is positive, they will get the disease, and we'll get to that. But the gene test is not necessary to do to confirm the diagnosis of the clinical disease if the typical symptoms are present and there's a clear family history. Before you get the gene test to confirm the diagnosis or in pre-symptomatic testing, the results have significant, really major social, financial, and psychological implications. And this is for people that are gene negative or gene positive. It really has significant impact on whole families, not just individuals. So this should be done only by clinicians that really know about HD. And the recommended team that's typically involved in getting genetic testing, again, symptomatic or pre-symptomatic, often there's a genetic counselor, hopefully a neurogenetic counselor, a psychologist, and again, a preferred, a neuropsychologist, a neurologist, and most importantly, a social worker. Negative or positive, the results can have widespread personal and family implications. If it's positive, obviously that has implications for the patient's future and says a lot for the family as well. If there are individuals that didn't want to get tested and are now known to be positive, that can cause strife within family. And negative tests are not always a positive thing. If someone doesn't go to college and they decide not to pursue a career because my grandfather had HD, my father had HD, I'm going to get it too, and then they find out they're gene negative, that can have significant implications. More commonly, it's more survival guilt. Why did my sister get it, whereas I didn't? In considering the gene test, often it's people who are at risk and not yet symptomatic who are requesting it. And some of the common scenarios that come up are family planning purposes, where the person's considering getting married or having children without the disease. In terms of financial planning, what job to take, what career path to take, whether to get particular insurances or not. And sometimes people just need to know. The uncertainty eats away at them and they lie in bed awake at night and have to know what the test results are. Some people need to hang on to that uncertainty and like the fact that they don't know. I often will get the gene test in people who are symptomatic, but there's no clear family history. Someone who's adopted, for example. If there's an early death in the family due to an accident or other disease, we may not know if that other family member had Huntington's disease or not. So to confirm, we can get the gene test. In juvenile cases, if they are symptomatic, to confirm it, that's another situation where you might consider sending off the gene test. And if there's anything unusual about the person in terms of their history or their physical exam, the gene test can be helpful to confirm Huntington's disease. We're going to, again, have a whole session on genetic testing, but as an overview, the gene test is not just a yes or no. We look at the number of repeats of a CAG, and this has been accurate and available for individuals since 1993. It has a very good sensitivity of 98.9%. When you get back the test, it's two numbers, allele 1 and allele 2, one from the father and one from the mother. In an expanded repeat range, the median number of repeats is 44. We consider repeat lengths of 40 or more to be a positive test, meaning that that individual will go on to develop the disease. But it's not always so clear. It's not always just a positive or negative. And these are some of the numbers that are published through the American College of Genetics. In the 27 to 35 range, the next generation is at increased risk for developing the disease, particularly from the paternal side. If you have 36, about 25% of people will develop symptoms depending on how long they live. Similarly, 37 repeats, 50% will develop the disease, 38 repeats, 75% will develop symptoms, and 39 repeats, 90% or more will develop symptoms. There are case reports, so really just a handful of people that have developed symptoms in the repeat length range of 29 to 35, but it's exceedingly rare and is really in the mutable range or the indeterminate range. People ask about whether the number of copies determines the course of the disease or the severity, and it really doesn't, but it does generally correlate with the age at onset of Huntington's disease. It's Huntington's disease, it's HD, and if you look at older literature, older billing slips, some current billing slips, it says Huntington's chorea, and chorea was and still is one of the main features of Huntington's disease, but it's really a triad. It's a movement disorder, and chorea is the main aspect of that movement disorder. But if you take away chorea, either through medications or look through that with the person in front of you, you see other movement disorders, Parkinsonism, dystonia, tics, others. It's also not just a movement disorder, which is true for many other movement disorders. It's a cognitive disorder. And often people's working memory or concentration and other aspects are involved. It's also a psychiatric and behavioral disorder. Depression is very common, up to 50% of people with Huntington's disease. Personality changes, impulsiveness, agitation, these are all quite common in people with Huntington's disease. Psychosis in the traditional sense in terms of visual hallucinations is unusual, but delusions do happen, and that can be a very difficult manifestation to deal with. So this is more than just chorea. It's really a triad of different constellation of symptoms. So also note that the diagnosis of Huntington's disease, again, I need to emphasize this, is not based on the results of genetic testing, but it's based on the expression of the motor signs. So it's just that first bullet point, the movement disorders, and some characteristic findings that we're going to go through. There's mounting evidence and pretty clear clinical impression that behavioral and cognitive issues predate motor issues in many cases and often are the predominant symptom that causes disability and reason to treat patients with Huntington's disease. We evaluate Huntington's disease based on the Unified Huntington's Disease Rating Scale, or the UHDRS. This is a good reflection of the fact that Huntington's is more than just chorea, that it's a disease that encompasses motor, cognitive, behavioral, and truly causes functional impairment. The first section is the motor assessment and focuses on some specific areas that are unique to Huntington's disease, such as eye movements, motor impersistence, looking at tongue protrusion. There are about 18 items in the motor section. The cognitive assessment similarly gets at a subcortical assessment of cognition. Behavioral assessment is undergoing some revisions, but looks at hallucinations, behavior, irritability, other aspects of behavior. Functional assessment is a 25-item checklist. Can the patient do certain aspects like work, take public transportation, care for themselves? Independence scale is a 0 to 100% scale of what percentage of their normal functioning does somebody have. And that can be used in patients with a bit more advanced disease as well. The total functional capacity, we're going to go into it in a little bit more detail, but this is how we stage the disease. At this point, the whole UHDRS is how we measure the disease and stage it. There is no biomarker. There is no blood test to say, oh, you're in stage 1 Huntington's disease. But that would be nice, and it's in development. I want to take a step back and go through some of each of the aspects of the triad. In terms of chorea, it translates from Greek for dance. And this is something that's easier to see rather than describe, but these are many of the descriptions that are written down. Excessive, spontaneous movements, irregularly timed, randomly distributed, and abrupt. They are abnormal, they are involuntary, they are rapid and sustained, and they tend to flow from one body part to another. Many times patients are aware of their movements, but many times they're not. They may be aware of the results of their movements, but not necessarily the movements themselves. For example, if they knock something off a shelf or a coffee table. At this point, I'd like to show you a video of someone with chorea. So this is a gentleman who has moderately advanced Huntington's disease, and you can see that he's got movements of his trunk, of his arms, a little bit of his legs. He really doesn't have much facial expression, even though he's talking with me. And that's some of the signs of Parkinsonism that you can see when someone doesn't have facial expressions. And even though they have, this particular patient has a lot of involuntary movements, there are very few voluntary movements. So he's not gesturing, he's not pointing, he's not having the usual types of voluntary movements that we might see. So a lot of involuntary, not a whole lot of voluntary, and facial expression is where I like to measure a lot of slowness as well. In terms of his walking, you can see that the movements persist. He is able to walk, and actually this patient in particular does not have balance difficulties, but balance difficulties because of chorea can certainly happen. Chorea is, again, I don't think I can emphasize this enough. This is not the only movement disorder that we see, and it's not in isolation either. So the last patient did have some dystonia, some postures that were more sustained. People on medications can have akathisia, or an inner feeling of restlessness that makes them get up and move. If you feel restless, chances are they do too, but they may not be able to express it as well because of their Huntington's disease. Myoclonus, or brief jerk-like movements, can happen as well. Tremor can happen either as a result of the medications or in more Parkinsonian forms of the disease. Tics or tic-like behaviors and sounds can happen as well, and rarely people can develop tardive dyskinesia, but this can be very difficult to distinguish from the chorea in the mouth region. These are some of the movement disorders that are seen in Huntington's disease in general and that you should look for, not just in association with chorea, but in isolation by themselves as well. Dysarthria can be its own movement disorder, and that loss of regularity of speech can be a cognitive aspect, but it can also be some chorea of the neck, diaphragm, chest wall muscles. Dysphagia, I put in the movement disorders section as well, because coordination of the swallowing muscles can be a significant issue. Ataxia can also show up as a separate movement disorder related to Huntington's disease, and that incoordination can cause some significant troubles for many patients. Alternatively, Huntington's disease is not the only cause of chorea. There are many causes of chorea, so when you see someone, you should think about a broad differential. Obviously, if it runs in families, then you should think about Huntington's disease, but neuroacanthocytosis is also a hereditary form of a neurodegenerative disease that causes chorea. There is a form of hereditary non-progressive chorea as well, and this typically shows up in older age. It's not clear if this is a separate disease or someone with Huntington's disease who has a very low number of repeats. There can be chorea based on developmental or aging issues, cerebrovascular disease. There's a rare disease called DRPLA. There are infectious causes that come up more often these days, such as Sydenham's chorea, and more specifically with HIV as well. SLE can be a cause of chorea, and this is often associated with lupus anticoagulant. Chorea gravidarum, and similarly related to medications, a high estrogen state can give chorea as well. Some of the leukodystrophies and gangliosidosis of childhood. Hyperthyroidism is an underappreciated cause of chorea. And there are many medications, but when we do it to people, we don't call it chorea, we call it dyskinesias. So these are tardive or levodopa-induced dyskinesias. Getting back to the genetics a bit, to expand on this, each child with an affected parent has a 50-50 chance of inheriting the disease. So this is regardless of whether the parent is the mother or father. Every child of a parent has a 50-50 chance of developing the disease. It does not skip generations, and if you don't inherit the gene, you can't pass it on to the next generation. That was George Huntington's contribution to the literature. The symptoms do progress over years and develop and begin insidiously, whether it's the motor signs, the psychiatric or behavioral side, or cognitive aspects of the disease. And it unfortunately inevitably leads to death. In terms of the cognitive disorder, it's a little different than a cortical dementia that you might see with Alzheimer's disease, for example. Typically, it starts off as a subcortical dementia. So this is bradykapnia, or slowness of thinking. And the memories may get in and may get out, but they're just a little bit slower. So that initiation of memory recall is a little slower. This can be quite impairing in social situations, for example, when there's a lot of conversation going around and the person is one sentence behind. They often will withdraw from social situations because of this aspect. There can be executive dysfunction, impaired judgment, and attention and sequencing impairments. And these last two, impaired judgment and attention, can be significant issues in people that have occupations that require obviously attention or high-level functioning. In terms of the behavioral disorder, affective illness is what we deal with most, because it's the most common. Depression and anxiety is in up to 50% of patients. Suicide is a significant issue, and we're going to talk a little bit more about this as well. Obsessive-compulsive symptoms and this idea of perseveration, getting stuck on one idea. Can I get a glass of water? I want a glass of water. Can I have a glass of water? Can I get that glass of water now? It can drive caregivers nuts. It can drive everybody nuts when the person is stuck on a particular idea. They can have true obsessive-compulsive disorder too, but this idea of perseveration is very common in Huntington's disease. Psychosis and delusions as an aspect of psychosis happens in up to 15% of patients and can be quite impairing. Sexual disorders, and given that this is a disease that often affects people in their 20s, 30s, and 40s, this can be a significant quality of life issue. Personality and behavior changes, and this can be much earlier than any of the motor signs and can be quite impairing for many people, and relationships as well. Sleep disorders is an aspect of Huntington's that we're just beginning to explore. Clearly, nighttime is not normal, but how sleep is disrupted, and obviously that can impact the next day in terms of fatigue, attention, and other cognitive issues as well. And impulse control is a major issue in people with Huntington's disease. Combine impulse control with affective illness, and you can see why suicide is a bit more common in people with Huntington's disease. In terms of the early disease, it really can present with any proportion of the three aspects, any of the triad. They, by definition, have to have some motor aspects. So there's some chorea that if you look for it, it will be there. Often there's some subtle dystonia, myoclonus, or tic-like behaviors in addition. They can have behavioral problems. People describe a sense of clumsiness. They're just not using their hands the way they used to. They can notice subtle walking changes, which goes along with clumsiness as well. There can be mild speech, rate, and rhythm issues, and this is where you can actually pick up someone's diagnosis over the phone before you've even met them. They can have subtle memory problems, and again, this isn't necessarily a cortically based. Information isn't getting in and out, but it's taking a lot slower to get in and out. And often when people are diagnosed, in retrospect, they notice that there was a preceding mood disorder, or a decline at work, or there were relationship difficulties. In terms of how we stage it and how we watch people advance from early to more advanced stages, it's based on the total functional capacity score. Now, this is a 13-point scale that's based on the person's occupation, finances, how well they can do domestic chores, how well they care for themselves, their ADLs, and where can they be cared for, where's their care level. And these are the stages. Stage 1 is generally scores from 11 to 13. Stage 2 is 7 to 10. Stage 3 is 3 to 6. Stage 4 is 1 to 2. And stage 5 is 0. And often people can, there's a floor effect at about 5 or 6, and people can be there for a very long time. In addition, people can be at stage 0 for 5 to 10 years. So more advanced stages, we really don't have a good way to address the progression through that stage of the disease. It's also difficult in children or young adults who may not have had the opportunity to work, or have never managed finances, or don't do any chores around the house. Those that have prominent psychiatric disease also may have great impairment in their occupation, finances, doing chores, caring for themselves, but may be physically very well off. In terms of more advanced disease, people often have much more stiffness and slowness of movement, the bradykinesia, and there can be these aspects can be more prominent than chorea, but chorea can also reemerge. It can reemerge in lower frequency but larger amplitude, so that some patients may throw themselves out of bed when all they're trying to do is turn over. And it can reemerge in much more frequent chorea. Unfortunately, I had a patient who was advancing through the stages, had much less chorea, then had a lot more chorea and wound up suffocating because she was wedged in a bed. That was related to her chorea in more advanced stages. They can have dystonia, which can be abnormal fixed postures, and this can be quite uncomfortable for people. And again, in late stages, can result in screaming, discomfort with routine nursing care. People can have weight loss as well. This is very common in more advanced disease, but can happen in early disease as well. Dementia, and this time more of the cortical type, is very common in advanced disease. And the rate of progression varies, but the disease duration typically is from 10 to 25 years, sometimes shorter, sometimes longer. As people progress from the early stages to the more advanced stages, they want to know what's associated with disability. When are they going to be disabled enough that they need more care, or they need to stop working or stop driving? And even though this is one of the most asked questions by patients, it's really not well studied. I want to talk a little bit about the neurologic progression and what's associated with disability. We're going to talk more about the administrative side of disability in another session. Studies to date in terms of disability conclude that cognitive dysfunction is one of the most important determinants of disability. The motor effects tend to be more disabling later, and they can be one of the effects that wind up, reasons why people wind up in a nursing home. Treating the motor aspects of Huntington's disease tends to have little impact, but this also needs further study because we really haven't looked at that. Most studies do examine later disease and not pre-symptomatic or early disease when it comes to disability. So here are a summary of a couple of the studies that have specifically looked at this. Some of the predictors of extended care placement: nursing home residents had worse motor function, chorea, bradykinesia, gait problems, and imbalance, and this is from the Unified Huntington's Disease Rating Scale. It's not surprising, since many patients who wind up in nursing home, they get in there easier if there's a lot more physical disability rather than cognitive. Although those that are in extended care facilities also are more likely to have behavioral disease, such as obsessions, compulsions, delusions, hallucinations. More disruptive behaviors, such as aggression and irritable behaviors, are also more likely to occur in patients in extended care facilities. When we looked at the entire Unified Huntington's Disease Rating Scale, these were the factors that were predictive of nursing home placement: impaired gait, impaired tandem walking, and bradykinesia. So the conclusion from Vicki Wheelock's study in 2003 was that motor variables alone predicted nursing home placement. In terms of those that are already in extended care facilities, here are two studies that have looked at the characteristics. Martha Nance in 1996 looked at a group of patients, and the average age was 45. The average disease duration was 10 years. It was about half women, and these were almost all previously employed and had a high school graduate degree. In terms of being unmarried, 44% were never, and 33% were divorced. That divorced is also maybe slightly elevated falsely, because there are some people who, for financial and legal reasons, got divorced so that there could be more care for their loved one with Huntington's disease. Vicki Wheelock in 2003 also looked at patients in extended care facilities. The average age was 52. The average disease duration was 8.6 years, and there was a few more women than men in her published study. When we look at the cause of death in patients with Huntington's disease, it's generally speaking related to loss of functions. That's complications of immobility: aspiration, pneumonias, nutritional deficiencies, chronic skin ulcers. And suicide risk is often brought up as in Huntington's disease. And about 25% of patients do attempt suicide at least once. It's the cause of death, depending on the study, 8 to 9%. The risk factors are typical for those for outside of Huntington's disease: childlessness, depression, single, living alone, other suicides in the family. But I also put this because there's a loss of function. When people transition from stage 1 to stage 2, they often lose functions such as working, driving, and that puts them at increased risk for suicide as well. Just moving into the treatment aspect of Huntington's disease, one of the first questions that's often asked is, why bother treating chorea? It's a cosmetic issue. The medications are only going to cause side effects. And so these are some of the reasons that patients come up and tell me, I'm happy to prescribe medications or not. I'm not the one that has to take it. I'm also not the one that has to live with the chorea. So people describe an improvement in their quality of life, and this is not just for patients, but for caregivers as well. If someone has enough chorea that they're not going out to restaurants or going out to social functions, if you suppress that, they can be a bit more sociable as well. Preventing injuries, banging into walls, knocking things over, so injuries not just to the patient but to households. There's a question of whether it can improve function or not, and this needs further study. And people say that it's a cosmetic issue, but it's not just a cosmetic issue. It's a significant issue, and it's also one that we can treat adequately. In terms of classes of therapies that we use to treat chorea, pharmacotherapy, and we're going to talk a little bit more about this in this talk as well as in Vicki Wheelock's. Surgery can sometimes be used in much more severe cases, patients who are falling out of bed because of chorea or broken bones because of injuries related. If medications don't do the trick, then deep brain stimulation or pallidotomies have been studied. Cell transplantation of various types has been attempted and is not currently standard of care. There are lots of complementary therapies that have been at least anecdotally reported: acupuncture, relaxation, massage, and anything that's going to bring the person's anxiety level, bring stress level, and more relaxation is going to reduce any excessive movement. So it's not surprising that these patients report that they feel better and their chorea is better as well. Chorea, when people move a lot, they also can lose weight. So sometimes treating chorea can cause weight gain. Vice versa, if you gain weight, that can also treat chorea. Physical therapy has been reported to help with chorea, and sensory stimulation can also sometimes help treating chorea. These are the classes of medicines and some examples of what are typically used to treat chorea. Dopamine depleting agents and tetrabenazine is the only FDA-approved medication in the U.S. for chorea and for Huntington's disease. Older neuroleptics, such as haloperidol, risperidol, and some others are commonly used as well. Some of the newer neuroleptics have been studied in Huntington's disease and can be effective in chorea, such as aripiprazole or olanzapine. Dopamine agonists in short bursts have been studied, but the long-term effects have not been studied. Cholinesterase inhibitors likewise have been studied in short term, as well as NMDA agonists such as amantadine and memantine. Cannabinoids for short term have been studied, but medical marijuana is not necessarily studied, shall we say, or condoned. In terms of GABA inhibitors, clonazepam has been studied, but usually the doses are too high to treat chorea per se, but they can be a very effective anti-anxiety agent. In terms of symptomatic treatments, it's not just chorea as part of the movement disorders, but dystonia can be addressed, and this can be through anticholinergic medications or botulinum toxin injections. Parkinsonism can sometimes be pretty significant and need to be addressed. Amantadine can treat chorea, but also can treat the underlying Parkinsonism if people have underlying tremors, slowness, or other signs of Parkinsonism. Psychiatric treatments we're going to get into a bit more, as well as non-pharmacologic interventions through the team approach. In terms of the movements, obviously treating chorea with medications or surgery, the slowness and stiffness with anti-Parkinsonian drugs, and I've mentioned already that dystonia, if it's focal and painful or interferes with hygiene or dressing, you can do botulinum toxin therapy. And benzodiazepines or anticholinergics can also help if it's a bit more widespread or segmental. In terms of overall thinking of treating a psychiatric aspect of Huntington's disease, for depression we use the antidepressants, and there are various classes of antidepressants that have been studied to a small degree in Huntington's disease. Hallucinations and delusions, we typically can use neuroleptics in those cases, and that can have some benefit on the movements in addition. There are some neuroleptics that cause weight gain, and that's probably a good thing in most patients with Huntington's disease. Sleep, I put under the psychiatric aspect as well, and behavioral measures are very common. To have someone lie in bed awake till 4 in the morning only teaches your body to be awake. So good sleep hygiene is the first measure in addressing sleep. Hypnotics can add medications, but can also help people fall asleep. And in Alzheimer's disease, it's been studied, and sleep disruption, particularly for caregivers, is one of the top reasons why people wind up in long-term care facilities, and that can be the case for Huntington's disease as well. In terms of some overall treatment strategies of the cognitive disorders, again, we're going to go into this a bit in other sessions, but for memory, recognition is easier than recall, so giving people a list to pick from can be a lot easier than an open-ended question. Providing hints, asking simpler questions, yes, no, rather than coming up with answers de novo. Learning can be very much impaired. This can be from the disorganization or poor attention, and executive dysfunction as well. So to break steps down, to break a task down into individual steps and provide simple and concrete instructions can be helpful. Don't just say, go make a pot of pasta. Tell them, get out the pot, fill it with water, put it on the stove, fill it up. So some routine things that we don't even think about today, if you break that up into individual steps, someone with Huntington's disease might be able to do that. Limiting distractions. We always have phones going off, TVs, There's the computer in the background. To limit distractions will actually help with learning. And it can be important to do that in different situations, such as eating, to prevent choking. So limiting distractions can be a very important aspect of care in Huntington's disease. Organization, so having lists in an obvious place in the home, or big calendars on the wall, and routines. Having a regular routine for someone to follow so they know what to expect and what to do next can help with organization and can help with them, with the person's functioning in the home. The bradykaphrenia is the slowness of thinking. So don't interpret a lack of response as a no response. Sometimes you have to wait, and in more advanced disease, sometimes it can be 15, 20 seconds. I'll never forget one of my first interactions with someone in a long-term care setting. I asked what he liked to eat, and he said, pizza. Took him a while, and he took a lot longer than that, but he got there. So have patience when you're talking with someone. Don't just expect a quick back and forth in terms of the interaction. In terms of non-pharmacologic interactions, I very much rely on my other therapists to help with the best care for my Huntington's disease patients. Social work, you have to have a social worker to address many of the issues that come up with Huntington's disease. Nutrition, social support around the person and their family, occupational therapy, physical therapy, speech therapy. Other therapists can play a key role in the treatment of someone with Huntington's disease. So in conclusion, Huntington's disease is an autosomal dominant disease that causes involuntary movement, cognitive decline, and behavioral dyscontrol. There are approximately 30,000 people with Huntington's disease, but up to 200,000 that may be at risk for getting the disease. Huntington's disease invariably progresses and ultimately leads to death from complications of immobility. The movements can be controlled mainly with medications, but the cognitive and behavioral manifestations may require both pharmacotherapy and non-pharmacologic interventions. Treating Huntington's disease requires a multidisciplinary team approach to best manage all issues that arise. That concludes the first module, and I hope that it was a good overview of Huntington's disease for you, and I hope that you enjoy the rest of the modules. Thank you for your time and attention.